Good morning, learned dignitaries, respected seniors, my dear colleagues and juniors. It's a matter of immense pride and pleasure to announce today's 28th CPC of this institute. This milestone reflects our unwavering commitment to academic excellence and evidence-based learning, making this CPC a legendary tradition to be carried forward by generations. With this, I would now like to welcome the dignitaries onto the dais. I would first like to welcome our respected Principal and Controller, Sir, Dr. Deepak Maheshwari, Sir, onto the dais. So kindly grace the dais. We are very grateful for your constant encouragement and visionary leadership that continue to strengthen our academic pursuits. I now like to welcome the Convenor CPC, Professor and Unit Head, Dr. Puneet Saxena, Sir, onto the dais. Sir, we appreciate you for taking this initiative and the owners for re-initiating this CPC and carrying its legacy. With this, I would now like to welcome our additional principal and co-convener CPC, Dr. Monica Jain ma'am, whose enthusiasm and meticulous planning and tireless efforts ensure the smooth conduct of these CPCs. And now, I would like to welcome finally onto the stage the master of today's ceremony, Senior Professor and Head of Department of Medical Oncology, Dr. Sandeep Jasuja, sir. So please grace the dais. So to begin with, I would invite Dr. Deepak Maheshwari, sir, to address the gathering.
Good morning, everyone. Hardly a gathering. Never mind. Oncology too. I was reading a paper today. So there was a big article on the breast cancer. So oncology is a burning topic. And with the increasing age of the country, the oncologists are going to be in big demand. We are keeping pace with the oncology services. We have started clinic and we are trying to make many new things. There is a little confusion in our center, so the pace, the growth is little hampered. But still, I think there is less number of faculties around. So everything is in our mind, and we are trying to increase the facilities day by day, and we are trying to keep pace with the increasing problem in the society. I think Dr. Jasuja is doing great work, and medical oncology required services of everything, the pathology and anesthesia and surgical things. So the combined effort is required. I think I don't want to much say. Please continue. Thank you.
Thank you so much, sir, for setting the appropriate context for today's CPC. Now I welcome Dr. Puneet Saxena, sir, to give the SOP of the CPC.
Good morning, everybody. Principal, sir, additional principal, Dr. Monica, Dr. Sandeep Jasuja, head of the department, senior members of the faculty, and dear friends. So today, as you just saw, that's to the 28th episode of the CPC. So we are here again for our academic and monthly academic meeting, but slightly disheartening to see very thin attendance, basically, and we were discussing before that. So before saying anything, I would request principal sir and additional principal sir that we should be bit stringent about the attendance in this academic program. This is the pride of college, and we should not let go of the waste of efforts of the presenting department and the people present over here to listen and understand that what is going on in the college. So today is the 28th, and we are left with few more departments. Ours is a bigger institute, so we are left with 4 or 5 more CPCs to go in this season, and then probably, as per the direction of the principal sir, we will start the new season. The next CPC would be done by the Department of Gastrosurgery, and I am afraid there is nobody from that department. And SOP, we all are aware that we just want to know about the department's progress in the initial few minutes, and then a crisp case which evokes the interest of all specialties, which touches the multi-specialty field, basically, right? So today, as we have seen that medical oncology is also a pioneer department, and it took baby steps in probably early 90s in this hospital, and it fully conceived under Dr. Sandeep Jasuja. And we are proud of you that you are doing great job at the State Cancer Institute now. So with that, I will just ask. So there is one big good announcement also that you can see all the CPCs which have been presented by scanning this QR code. You can go to YouTube directly and you can visit see all the CPCs which have been presented. And we would like to publish a compendium of CPCs also. So as discussed with Principal Sir previously also, we will request all the presenting departments to furnish the details of the CPCs they have presented. So we can publish a compendium of CPC from SMS Medical College. Thank you very much.
I would now like to invite Senior Professor and Head of Department of Medical Oncology, Dr. Sandeep Jasuja, sir, to take us to the glorious achievements of his department.
So, good morning everyone, and greetings from Medical Oncology Department. Thanks to Deepak sir, Puneet sir, and Monica ma'am for giving us the opportunity to present our CPC here. And warm welcome to all our faculty, resident, and my colleagues and senior teachers. So, today I am presenting the CPC of my Medical Oncology Department. The central message of presenting this CPC is to highlight our work, what we are doing in the Medical Oncology Department, and what the academic activity we are achieving, and what kind of facility and treatment providing to the patients, and high advanced facilities like transplantation service or medical oncology and genomic services. I will cut down my presentations within short because of the lack of the time. So our department built around the comprehensive care platform. It's not like a cancer unit, only chemotherapy units. It's expand from the clinical care, like providing the facilities to the patient, providing the services to the patient in OPD, IPD, and having the bone marrow transplant service. And we have also doing a DM training program and registry. Our moral responsibility to take and lead the government issues. So that's why we are also a nodal center registry, nodal agency for the cancer registry. So our theme of service, innovation, education, prevention is our departmental identity. So coming to the faculty leadership, myself, Dr. Sandeep Jasuja, heading the Department of Medical Oncology and also Medical Superintendent of State Cancer Institute. Along with me, Dr. Mukesh Rulania, who is associate professor in our department and contributed in a very highly way in the departmental development, academic activities, and also to structure the departmental infrastructure. And also, any department can grow only by the collaborative efforts. And I'm also thankful to our residents, sports, nursing staff, and pharmacy, and all support given by our principal sir and government to develop this department. So if you look at the bed strength, we have 144 beds strength. Out of 44, we have 44 daycare bed strength, and we have also hired 26 beds from the RUHS because we have huge workload, and we have 5 ICU beds because this patient also come in septicemia, and septicemia sometimes very serious and in last days. So this is our daycare ward. This is very nicely, beautifully constructed daycare ward, and the cleanliness and hygienist is very good. And we provide all kind of facilities to these patients at the doorstep, like essential basic facilities. So these are also our ward. See the ward. This is also ward. We have also toilet beds in our ward, and we provide like ICU kind of facility to the patients. So our OPD is structured to extend into the 6 days OPD. So 5 days OPD we have at the State Cancer Institute in room number 14 and 16, and 1 day Tuesday at the Navantri OPD in SMS Medical College at 48 number. So this kind of redistribution also facilitate the patient to take the facilities at their own choice. So if the patient coming to the SMS nearby SMS, they can avail the facility at SMS, and if the patient is far away from SMS and from that Pratapnagar side, they can avail the facility from the cancer center. So this slide is very important slide for us. See the expansional growth of our department. From 2022, just we have 4.3 thousand patients. Expansionally growth to 44,000 patients in 2024. More than 10 times increase in OPD and more than 7 times IPD. So this is never numerical value, but also show the trust the patient who appear in us, and also the facility expanding, and also patients who are not going outside of Rajasthan and staying back to with us. Now, after 2024, just see the huge expense OPD and IPD in 2025, just doubled after 2024, and 20 times more than 20. And more up to 90,000 patients we have catering last year, and 36,000 more than patients in IPD.
So do you mean to say that the incidence is rising of cancer patient, or your?
So ma'am, global data shows that the incidence is rising in 10 to 12% patient, but somehow we have made an advanced facility here, and we are providing the advanced facility and expanded the infrastructure. That's why patients are trusting more on us and coming to and staying back to us. That's why it looks like our incidence is increased. You can see that in 2024 we have delivered 20,000 chemotherapy in a patient. This shows our workload at our department, and not only chemotherapy but also target therapy. We have 400 to 500 patients per month. We provide targeted and immunotherapy, and these all are protocol-based driven treatment to the patients. And we manage all kind of treatment, all kind of toxicity, and provide the daycare facility, inpatient chemotherapy, immunotherapy, and also manage the toxicities of the patients. So this slide highlights our advanced strength of the medical oncology, because we are providing 400 to 500 patients per month with targeted and immunotherapy. This can be only provided when you have a very advanced infrastructure with you and highly expertise doctors with you and clinicians with you. So they need genetic profiling, they need personalized care, they need modern systemic therapy. So that's why our department is very much upgraded department now. So precision oncology servicing model relies on the 4 pillars. Like first, when patient comes, we do a testing by NGS, ISE and FISH. And with SurVision, now we are going to shortly start the molecular oncology lab in our SMS hospital or State Cancer Institute. And then after testing, we just pick up the marker, which is the target gene, and then we match the drug by tumor profile and patient profile. And after that, we treat and choose the drugs according to the tumor profile or gene profile. And track is also very important, because you want to know what is the response of the patient and what was the follow-up of the patient. So sometimes procedures are sub-underscored. So, but somehow we have to highlight the procedure what we are doing in our departments. We do a bone marrow aspiration biopsy, PICC line insertion, pleural and ascites tapping, lumbar puncture and IT, intrathecal chemotherapy, transfusion and line care. So we did PICC line insertion in 2022 to 45, which is almost double in the 2025 from 2023, and still in the halfway, within 6 months we crossed the 40 of more than 40. These are our leukemia ward. So important is leukemia ward, because blood cancer patients needs a very complex kind of management. They are neutropenic, they may have immune reactions. So that's why this leukemia ward is cabin, and they are isolated, and we provide all facility according to their needs. So this is our flagship program, bone marrow transplant, and we do all kind of bone marrow transplant, autologous, allogenic, haploidentical. These are all complex transplantation, but we do in our department. So we take pride that we have conducted the first bone marrow transplant in the history of Rajasthan, way back around 16 months, 13 years before. And we started, and because we know the transplant is only hope in some patient where they can have a cure, they can, but the transplant facilities were not available in the Rajasthan, and they have to go outside and expend expenditure. They have to do expenditure from their own pocket. So that's why in government sector impact is very important to start these services. We also take the pride to announce that the first allogenic transplant conducted by our department in the history of Rajasthan. And more complex transplant like latest advanced transplant, haplomatch transplant, where the patient don't have a donor, but somehow each and every patient have a family donor. So family donor can be matched halfly, if not fully, then we do half match transplantation, and this is very complex transplantation. So this itself speaks the expertise and advancement in our medical oncology department. So this is human impact of a story. Treatment is not a one part. This is one part, but human impact. This guy, young boy, was suffering from MDS and have not any major resources with him. So we did a transplantation. He successfully overcome from the transplantation, and now he is one DSP in our area. So our department also take the challenge to do a complex bone marrow transplant. This is young student from our own institute, from SMS Medical College. He was suffering from aplastic anemia, received ATG, no response. Then he led up in a septicemia and transfusion support system. But we took the challenge. We did the transplant, haploidentical transplant, and he is now fit and fine and pursuing his career in the UPSC. So one more important point, always people say that this age we can't do transplantation, this age, this is 65 years, 40 years, 50 years, but somehow age should not be a barrier to conduct that transplant. As if patient is fit for their comorbidity, there is no comorbidity, or patient is fit and healthy and the performance data is 0 to 1, we can pick this kind of patient for the transplantation. We did this transplant in 17 years, around 10 years back, and now he's still happy and healthy and enjoying the good life. And this patient was suffering from multiple myeloma. So we also expand our horizon to the medical tourism. We did a transplant in Nigerian patient, and he is doing well. And our also future vision is to start the medical tourism in the state cancer institute. So our clinical footprint is to take care of the patients of solid tumor, hematology, leukemia, myeloma, BMT transplant, support, targeted therapy, and immunotherapy. So the patient comes through the OPD, IPD, OPD, and evaluated for the IPD, and if need, then he go to the chemotherapy in the daycare or ICU or ward, or also referred to the transplant patient. And ultimately, he is enrolled into public cancer registry. So this was the first landmark when we crossed 10 years before. 50 bone marrow transplant marked a major state level achievement, and we were the first in the country to achieve this milestone at that time. So till date we have conducted over 180 transplantation, and out of 9 we successfully 90% is still alive patients and have no comorbidity or anything else. But somehow this speaks that not only innovation is important, but sustainability is also very important. So that's why we are continue providing the services to the patients. So we also do a rare kind of transplantation. This patient unfortunately failed after one haploidentical transplant. There was no other option for her to save the life, because now this transplant is complex, second transplant complex, because patient did not recover from the first transplant toxicity. His condition is still bad, but we took the challenge. We did this rare transplantation, second transplantation, and haploidentical transplantation, and patient survived. And we are planning to submit this in the international journal. So, looking at our load and waiting list in the cancer patient for the bone marrow transplantation, now government is very sensitive, and principal sir is very moving forward to provide this all facility, 50 bed bone marrow transplantation bed unit at State Cancer Institute. This will be the first highest largest bone marrow transplantation unit in the India, and will cater to all patients
What
of
is
the
the
state.
5-year survival rate of bone marrow transplant patients?
So, ma'am, that depend upon the transplantation. Which kind of transplant? If you do autologous transplantation, 5-year survival is around 80%, and if you do allogenic transplantation, it comes to 60 to 70%, and haplo again 50 to 60%. So this is some glimpse of our under constructing bone marrow transplantation unit. So we have also responsibility to conduct the academic activities, and we have started DM program from 2021. We have 2 seats with structured 3-year training, and now we are planning to expand in 5-year, 5 seats per month per year. So our academic culture, we do a departmental seminar, journal clubs, case discussion, multidisciplinary tumor board, protocol-based clinical training, and bedside training, bed and bedside training. So these are our publication, more than 50 publications in national and international we published. So we have also responsibility of prevention of the cancer. So that's why we conduct the vaccination, HPV vaccination camp at State Cancer Institute. And also we are the leadership, we have to take the leadership responsibility for the cancer registry at the state level. And this will standardize the reporting, clinical and cancer burden mapping, will done cancer burden mapping. And also, if we have a data of all cancer patients, we can use this for the policy making and source planning. So, our dream is to make the cancer treatment under one roof. That's why the Cancer Institute, State Cancer Institute started, and now shortly we will have all kind of facility under the one roof. So our vision is to expand the bone marrow transplantation to 50 bed, one of the best in the India, and also to make a precise treatment to the patient, provide a precise treatment to the patient by giving this molecular oncology target-driven treatment, and also strengthen the cancer registry. Dr. Manu, I would like to invite Dr. Manu for further proceeding.
Good morning, respected faculty members, seniors, and my batchmates. Today, the topic of our CPC is the vanishing rectal cancer is cure without surgery possible. So, first we'll talk about the patient story, clinical presentation. So, a 28-year-old lady presented with chief complaint of bleeding per rectum for last 3 months, unintentional weight loss for 6 months, and altered bowel habit for 6 months. There was no frank obstruction, no jaundice or ascites, no cough, hemoptysis, no bone pain, no any significant family history, and no neurological symptoms. On general examination, she was conscious, cooperative, well-oriented to time-place person. There was no pallor, recurrent sinus clubbing edema or peripheral palpable lymph nodes. She was hemodynamically stable, as applied, with performance status 1, and she was fit for curative intent therapy. On systemic examination was normal. Local examination on inspection, local perianal examination. Perianal skin was healthy. There was no external mass, no fissure or fistula. There was no active external bleeding. So, anal wall was externally normal. On digital rectal examination, anal tone was preserved. There was a low rectal lesion, 3 centimeters from anal verge, which was formed. Firm growth was present on the posterior rectal wall from 4 o'clock to 8 o'clock position, and blood staining was present on the gloved finger. So, based on the DRE findings, there was no gross sphincter involvement, there was no obvious pelvic fixation, there was no external perineal extension. So, it was a clinically low rectal cancer. So, clinical impression before we further went to investigation, it was a 28-year-old lady with bleeding PR and weight loss, lower rectal and anorectal neoplasm likely, but tissue diagnosis and endoscopy and systemic staging was necessary before we move forward for the treatment. So colonoscopy was done. On initial colonoscopy, there was suspicious low rectal lesion. Anal tone documented was normal. There was firm lesion near anal verge, which was polypoidal and irregular mucosa. So this established low rectal location. On diagnostic colonoscopy, inspection and PR tone was normal, and up to 10 centimeter was seen, and there was a friable vascular growth. So based on the colonoscopy finding, it was an anorectal and distal rectal growth near the anal verge and soft friable vascular lesion involving less than 1/3 of circumference. Important thing is scope was negotiated across the lesion, so it showed that there was no complete obstruction and multiple biopsies were obtained. So now I will like to call Dr. Master Dixon, Senior Resident, Department of Pathology, to give us pathological perspective.
Good morning to all. I'll be providing the pathological perspective of the given case. We received the fragmented mucosal bits which were labeled as anorectal growth. And on the microphotograph, this is the pre-therapy. The section shows mucosa which was composed of irregularly shaped angulated glands along with foci of necrosis. So, here. These are the angulated and fused glands. This is the high power view of the focus. Here, the irregularly shaped angulated and fused glands. The glands are lined by 8 typical columnar cells with hyperchromatic and enlarged pleomorphic nuclei. There is prominent nucleoli and moderate amounts of eosinophilic to amphophilic cytoplasm. There is stromal desmoplasia and infiltration of malignant cells into the mucosa. The final diagnosis on the basis of histomorphological features, it was given adenocarcinoma grade 2 moderately differentiated with 50 to 90% gland formation. I would like to call Dr. Ayush Khandelwal, Assistant Professor, Department of Radiology.
Good morning, everyone. I will be presenting the radiology perspective. So, in the PET CT, we can see there is an FDG avid lesion in the placed eccentrically, covering the right posterolateral wall of the lower rectum and extending into the anorectal junction. The approximate length of the lesion was around 3.5 to 4 centimeter. It was predominantly intraluminal and had slight extraluminal extension into the perirectal fat. And the distance from anal verge was around 2 to 3 centimeter. And in the subsequent slide, we can also see there were few subcentimetric regional lymph nodes as highlighted. We had presacral, mesorectal, as well as some nodes along right internal ilii. They were all subcentimetric. And this is the coronal view, which showed there is no evidence of any distant metastasis into the liver, peritoneum, or anywhere else in the body, and the disease was localized to the distal rectum as the anorectal junction. So this was the summary as I have explained. Now a few words about role of MRI in CA rectum. First of all, it is a gold standard when it comes to the local staging. For the T stage in particular, as it accurately differentiates T1, T2 from T3 as well as T4 tumors. It also helps in the assessment of circumferential resection margin, which is a strong predictor of recurrence, and also it helps in the extramural vascular invasion. It is also like the modality of choice to assess the extramural vascular invasion. Also, it gives the detailed anatomy of the sphincter involvement along with superior nodal mapping, since we can get an idea about the nodal morphology, the characteristics, and this was for the primary staging, and apart from that, it is also helped in the restaging, because with MRI we can have diffusion, which helps it to assess the tumor regression. So coming back to the case, the final conclusion from the PET-CT was that it was a low rectal and anorectal location lesion, which was predominantly intraluminal with slight extraluminal component, and along with that, there were few subcentimetric mesorectal, right internal iliac, presacral lymph nodes, but without evidence of any distant metastasis. Now I would like to call Dr. Anika Mehra for the treatment.
Morning everyone, I will be presenting treatment part of this case. I will briefly discuss treatment of localized rectal carcinoma, how treatment has evolved from traditional approach to modern total new agent treatment, and treatment journey of our patient. So, before deciding the treatment plan, we staged the patient with PET-CT scan. The primary tumor was located in lower rectum, invading through muscularis propria into perirectal fat, corresponding to T3 disease, and there were few enlarged regional nodes, and there were no findings suggestive of distant tumors. The clinical stage was clinically T3, N1, N0. So, after clinical examination, colonoscopy, and PET-CT scan, final pre-treatment diagnosis was lower rectal adenocarcinoma, moderately differentiated, clinical stage T3, N1, N0, stage 3. So, our intent was curative, and because it was a lower rectal carcinoma, so our intent was not only to cure the disease but also organ regeneration. So this case raised 4 important clinical questions. First, what is the best treatment for a young patient with low rectal adenocarcinoma? Second, how can we maximize tumor regression before deciding on surgery? And if the patient achieves clinical complete response, can we preserve the rectum? And what are the evidence supporting total new agent treatment and wait and watch approach? So, to answer all these questions, I will discuss how treatment has evolved from conventional approach to modern paradigm of rectal cancer management. So, conventional rectal cancer management followed 3 steps. First, neoadjuvant chemoradiation to downstage the tumor, followed by total mesorectal excision, which is cornerstone of the therapy in conventional approach, followed by adjuvant chemotherapy. Although this approach has excellent oncological outcome, but there are several limitations, such as many patients were not able to complete post-op chemotherapy because of surgical complication and delayed recovery from surgery. And surgery in low rectal cancer may need permanent stoma, and there is risk of bowel, bladder, and sexual dysfunction. And many patients who achieved complete response were overtreated. So this limitation led to development of modern paradigm of rectal cancer management, which is more personalized, multimodal, and organ-preserving approach. There are 4 pathways we can follow in modern paradigm. So first is TNT, which is most common used approach, where all the systemic therapy is given before surgery. Second is neoadjuvant chemotherapy with selective use of radiation. In selected patients who achieve adequate response with neoadjuvant chemotherapy, we can avoid radiation and can directly proceed with surgery. Third is wait and watch approach, where selected patient who achieve complete response with neoadjuvant therapy, we can avoid surgery and can go for intensive surveillance. And fourth is for patients with MSI high tumors, where neoadjuvant immunotherapy has emerged as highly effective approach for organ preservation. So what has changed in modern paradigm? The biggest change is the surgery is not automatic for every patient. Treatment is more response adapted, and systemic therapy has moved earlier in the treatment plan as a part of TNT, and organ preservation with a legitimate endpoint in selected patient who achieves complete response. And surgery remains essential for patients who have incomplete response or develop regrowth during the follow-up. So I will briefly discuss treatment of stage 1 and stage 2 rectal carcinoma. For stage 1, surgery is the main treatment, ranging from local excision to total mesorectal excision depending on tumor characteristic. For stage 2, the patient with favorable risk factors without threatened MRF and EMVI positivity, these patients can be considered for de-intensification strategy, and patients with high risk factors are considered for TNT. So, management of stage 3 rectal carcinoma. selected patient without risk factors can be considered for de-intensification stage 3, but most patients in stage 3 rectal carcinoma requires total new urgent treatment. So, core principles in the management of stage 3 rectal carcinoma. Any regional node involvement makes it stage 3 irrespective of T stage, and treatment is decided by tumor location, nodal burden, and resection morbidity. So, this lower rectal stage 3 carcinoma strongly favors total new urgent treatment therapy, and organ preservation become meaningful only after complete response assessment. So, our case was not treated by upfront surgery because of these reasons. First, the tumor was located in lower rectum, so surgery had higher chances of sphincter loss and permanent stoma. And regional nodal disease suggested that it was a low rectal adenocarcinoma, so TNT is the preferred approach here. And the new adjuvant therapy would downstage the tumor and which would improve the local control and improve surgical options. And if the patient achieves clinical complete response, then organ preservation pathway can be offered. And throughout the treatment journey, our intent was curative. So, treatment journey of our patient, after diagnosis and staging, we administered long course chemoradiation therapy first, followed by consolidation chemotherapy, and at the end of treatment, response assessment was done. So, we chose long course chemoradiotherapy first because it is a standard new urgent treatment for locally advanced rectal carcinoma, forms the backbone of TNT, and we aimed at to maximize tumor regression, increasing probability of clinical complete response, and facilitate organ preservation through wait and watch approach. So, after completing chemoradiation, we provided consolidation chemotherapy. Consolidation chemotherapy after chemoradiation, as the radiation-induced tumor regression continues after weeks completing chemoradiation. So, we use this waiting period as active systemic treatment time by giving chemotherapy. And early chemotherapy treats occult micrometastatic disease, and patient compliance and treatment completion are better before surgery rather than after surgery. And evidence suggests that consolidation increases chances of clinical complete response and wait and watch. So, as consolidation chemotherapy regimen, we chose capecitabine with oxaliplatin, as it is a well-accepted oxaliplatin-based regimen in TNT. It targets both primary disease and occult micrometastasis, which reduces risk of distant relapse. And capecitabine is an oral drug which is convenient for the patient on outdoor basis. It avoids need of central venous access and continuous IV infusion. So, it is an excellent balance of efficacy, convenience, and tolerability, making it as a reasonable choice for consolidation chemotherapy. So, the regimen, the oxaliplatin was given at a dose of 130 mg per meter square on day 1. Capecitabine 1000 mg per meter square BD for 14 days, followed by 7 days rest. Cycle length was 21 days, 6 cycles were given, and with curative intent. So, before giving consolidation chemotherapy, we made sure the patient was fit to receive chemotherapy. Clinical and lab assessment were done. Patient had adequate ECOG-PS nutritional status and no significant comorbidities. Lab assessment were performed, and there were adequate blood counts, adequate renal and liver function test. So, during the chemotherapy, we monitored the patient for toxicity, specifically like hand-foot syndrome, diarrhea, myelosuppression, mucositis with capecitabine, and acute cold-induced neuropathy, cumulative peripheral neuropathy, and hypersensitivity reaction with oxaliplatin. Supportive care was provided during chemotherapy to ensure maximal treatment adherence and treat toxicity early. So, for nausea and vomiting, we gave 5-HT3 antagonist and dexamethasone as required. Patient was advised for adequate hydration and use of loperamide in case of diarrhea, and emollients were advised for hand-foot syndrome. And patient was asked to avoid cold exposure during oxaliplatin to avoid cold-induced neuropathy. And in case of significant toxicity, dose modification was done. So, after completing chemoradiation and adjuvant consolidation chemotherapy, the final decision depends on response assessment. At this point, we have two possible pathways. If the patient achieves clinical complete response, then we can avoid immediate surgery. We can preserve the rectum and sphincter, but it requires strict surveillance. And if the patient develops regrowth during the follow-up, salvage surgery is to be performed. But if the patient does not, on the other hand, if patient does not achieve response and there is residual tumor, then surgery has to be done, but organ function may be compromised. So, treatment summary: the patient presented to us with bleeding per rectum and weight loss. The diagnosis was made as well differentiated rectal adenocarcinoma of stage 3, lower rectum. So we provided long course chemoradiation followed by consolidation chemotherapy. Throughout the treatment journey, our intent was curative with organ preservation. Final decision depending on response assessment. I now invite Dr. Divya Satma.
I have a question. How much was the period of remission? When did you actually take the patient for treatment? What was the date? How much was the remission period?
Ma'am, we have followed the patient for 9 months.
9 months. And how do you treat the bleeding part?
So ma'am, that is the treatment part only.
Cure. CTM. Cured by CTM. Treatment which we given chemoradiation and chemotherapy.
Good morning, everyone. I will be discussing the radiation oncology perspective for this case. So, young lady with lower rectal growth and locally advanced rectal cancer stage 3 was referred to a department for preoperative radiation therapy. So the question is why preoperative radiation therapy is considered the backbone of total neoadjuvant therapy. So the preoperative radiation therapy addresses two factors. First in terms of tumor and another in terms of patient. For tumor factor, it downstages the tumor and increases the likelihood of R0 resection and maintains the quality of life of the patient by preserving the sphincter as well as the organ. And in terms of patient, it is better tolerable as well as has a good compliance. And it is supported by high level of evidences as displayed. Radiation regimens. Usually two radiation regimens are followed. One is short course radiation therapy and another one is long course. The short course is delivered within 5 days and a higher dose per fraction over a shorter period of time is given and is usually indicated in early stage cancers where the quick surgery is planned. And contrary to this, a long course CTRT usually takes 5 to 6 weeks to get delivered and a lower dose per fraction is given. And it is indicated for better tumor downstaging and where the main goal is to preserve the sphincter and organ in locally advanced rectal cancer. So the plan for this case was long course chemoradiation therapy planned by image guided radiation therapy. 50.4 gray in 28 fractions were planned at a dose of 1.8 gray per fraction to the pelvis. 45 gray was strictly given to the whole pelvis with an additional boost of 5.4 gray to tumor bed. And a concurrent capecitabine chemotherapy at a dose of 825 mg per meter square was given along with RT. And it was delivered for 5 days per week, giving a rest for 2 days. So the techniques of radiation delivery, the very first step is CT simulation, where the patient is positioned in supine position and a thermoplastic mold is made for the immobilization of the patient and a strict bladder filling protocol is repeatedly followed for the reproducibility at every fraction and better treatment outcome. This is the main part of radiation. The image is called, the CT image is contoured. As you can see, the red color depicts the gross tumor volume, which is the primary tumor. Adding few microscopic margins, a clinical tumor volume is generated, which addresses the microscopic disease. And yellow one depicts the internal target volume, which addresses the internal motion of the organ like rectal, filling, peristaltic movements. And final is the blue one, planning target volume, which addresses the setup errors and the invariabilities during the treatment.
What about the lymph nodes?
Lymph nodes, elective lymph nodes are also contoured and they are considered in a final planning target volume. The organ at risk. While irradiating the tumor, certain nearby organs do receive the radiation and when their limit is exceeded, they produce toxicity. So a strict planning and a very nice contouring for the organs nearby is to be done. And the organs at risk in this case is urinary bladder, small bowel, femoral heads and spinal cord. And there is a radiation toxicity limit which has to be strictly followed and it is maintained by a very nice and vigilant planning. So this way the radiation was completed well in time with a duration of 5 to 6 weeks. And we did encounter some toxicities which were managed through supportive care and then patient was referred back to medical oncology department for further systemic therapy.
Now I would like to invite surgical oncology perspective for this case, Dr. Subhashini Rao.
Good morning. So I'll just briefly talk about the aspect of the surgical oncology. So this is the NCCN guidelines. So any patient, as in this case, was T3N1. So usually they go with a long course CRT followed by chemotherapy, either in the induction or the consolidation form, and then re-engage the patient after the treatment, and we go ahead with the surgery in the form of a transabdominal resection. So the surgical options for low rectal cancers include an ultra-low anterior resection, intersphincteric resections, abdominopelvic resections, and in advanced cases with total or posterior pelvic exenteration. The first two are sphincter preservation approaches, and the last two require a permanent colostomy. So the surgical technique is the total mesorectal excision, which was a concept given by Heel, which includes the rectum and the surrounding fat pad, which is called as the mesorectum, which contains the lymph nodes. So it includes a sharp mesorectal dissection within an intact mesorectal envelope, which helps to reduce the local recurrence. And that is the standard surgical batch. Wait and watch approach is usually done for patients who do not themselves wish to undergo surgery, who are too unfit to tolerate general anesthesia, and patients who are willing for a strict follow-up after complete response. Surgical complications include, usually they are minor, low anterior resection syndrome, usually self-remitting within a few months, mild urinary dysfunction or sexual dysfunction, and stoma-related morbidity. However, with good technique and with proper patient counseling, these symptoms or complications can be usually minimized and controlled and should not deter the patient from surgery. So now I'll call Dr. Manusha for further discussion.
So the patient had received complete and total neoadjuvant therapy, that is a long course chemoradiation followed by 6 cycles of consolidation chemotherapy in the form of capecitabine and oxaliplatin regimen. So after that, we have to do response assessment to decide the further course of the treatment. So for response assessment, we did a follow-up colonoscopy 4 weeks post-treatment, which showed per rectal examination was normal and there was normal mucosal vascular pattern. There was no obvious residual mass documented. And the second follow-up colonoscopy was done 16 weeks post-treatment, and it also showed NL2 was normal with altered mucosal patches. So for that, we did multiple biopsies were taken. So I like to call Dr. Mansi Dixit for pathology to discuss on the biopsy.
The post-therapy biopsy was received and the section showed rectal mucosa with well-formed glands and no evidence of desmoglesia or mucosal invasion. There was no viable tumor seen in the submitted biopsy and only chronic inflammatory cells were seen. The histomorphological examination favored non-specific proctitis with no viable tumor tissue in the submitted biopsy. Dr. Ayush Khandelwal for the discussion.
Now, in the PET-CT, which was done 10 weeks post-treatment, we can see there is no focally active FDG-avid lesion seen in the lower rectum or anorectal junction region. Along with that, there was disappearance of the regional lymphadenopathy, and this is the pre and post image. In the pre-image, we can see the FDG-avid lesion, which has completely resolved in the post-treatment PET-CT. The lymph nodes have also resolved, and there is no appearance of any new lesion anywhere else in the body. So, based on these findings, we can infer that because of the complete resolution of the rectoanal lesion and the pelvic lymphadenopathy and no appearance of any new lesion, there was complete metabolic response. Now, I would like to call Dr. Manusha.
So as seen, based on the colonoscopy finding, PET-CT finding, and on the biopsy also, the patient was in complete clinical response. So now we have to decide what we have to do after the patient is in complete clinical response. So conventional answer is we have to go for surgery because surgery confirms pathology. But the risk with surgery is also that surgery also risks stoma, low anterior dissection syndrome, urinary and sexual dysfunction. With the modern paradigm, if complete clinical response is verified, as in this case, so observation can preserve the rectum while retaining the salvage surgery as a backup. So, but we have to meet all these three domains should be satisfied to keep the patient on watch and wait list. So first we have to see the tumor response. There should be complete clinical response or sustained near complete clinical response. There should be no visible tumor, no palpable mass, no new disease. A patient should understand that there is a risk of regrowth and should be willing for follow-up and should actively report any symptoms and should accept salvage surgery as an option and should have access to endoscopy, surgery and imaging. The local regrowth risk, as seen in the International Wait and Watch database, 25% chances are there for local regrowth within first 2 years. The regrowth is mostly endoluminal, which can be easily detected on digital rectal examination and endoscopy, and is easily salvageable.
Dr. Malak, you did a post anesthesia, post treatment biopsy also, but in response assessment, is it necessary?
No, it is not necessary because there was some mucosal patches. For that we did biopsy. It is not necessary to do biopsy. So the price of organ preservation is disciplined follow-up. What we have to do in surveillance? Why the first 2 years matter? Because there is the highest risk of regrowth in the first 2 years. In 3 to 5 years, the risk is low, but we have to continue the structured review. And after 5 years, it is individualized. So for the first 2 years, this is the intensive phase of surveillance. Every 3 months, the patient should visit the clinic, and we have to do digital rectal examination every 3 months and flexible sigmoidoscopy every 3 to 4 months. And if there is any suspicious changes, we have to do biopsy for them. For systemic surveillance, we have to do CEA every 3 to 6 months, MRI rectum every 6 months, and CT PET-CT is available, and colonoscopy at 1 year. At 3 to 5 years, we extend the duration of follow-up, digital rectal examination and sigmoidoscopy now at every 6 months, imaging annually or as indicated, and colonoscopy is repeated at 3 years, followed by every 5 years. So what's the evidence for wait and watch? It all started with, in Brazil, in Habergama, she was a surgeon. She selected the patient who had complete response and decided to follow up them and under strict follow-up and should not do immediate radical surgery. So this was the concept by Habergama, and this created the wait and watch paradigm, and also generated the prospective trials. So in the Habergama, in the early series, there were 71 patients who had complete clinical response. They were observed without immediate surgery. The 5-year overall survival rate was 100% in the early case series. And the disease-free survival, 5-year disease-free survival was 92%. Now, International Wait and Watch database, this is the largest real-world validation. This is the global wait and watch registry. So every patient who is undergoing wait and watch is registered in this. Total 880 patients till now has entered wait and watch registry. So the 2-year regrowth, cumulative local regrowth is 25.2%, but the 5-year disease-specific survival is 94%, which is very good. And now there was a prospective trial, that is organ preservation in rectal adenocarcinoma. They took stage 2 and 3 rectal cancer and treated with TNT. For TNT, there are 2 sequences we can use. That is, first we can give induction chemotherapy, followed by chemoradiation. Other is, which we followed in this case, that is chemoradiation, followed by consolidation chemotherapy. The endpoint was disease organ preservation in this trial. And the surgery-free survival was better in the chemoradiation followed by consolidation chemotherapy arm. And so in this case, we followed this only, that first we gave local long course chemoradiation followed by consolidation chemo for better organ preservation. So to conclude, it was a locally advanced low rectal adenocarcinoma treated with total neoadjuvant therapy, had clinical complete response with complete metabolic response, and patient is planned for wait and watch surveillance and with salvage surgery as an option for regrowth. Now I will like to call Dr. Sandeep Jasuja sir to conclude the presentation.
So, wait and watch provided major benefit, but this benefit comes with a clear responsibilities. On the benefit side, the patient avoid immediate surgery, immediate total mesothelial surgery and abdominal resection, and avoid upfront permanent stoma, and has a better chance of preserve bowel, urinary, sexual functions, and also body images. However, this approach is not risk-free, and local regrowth occur in approximately 20 to 25% patients. (20 to 25% of patients), and most regrowth are detected during the first 2 years. So it is very important for us to this is not a passive surveillance, it's a very active surveillance. We have to do an active surveillance in this patient. And whenever we are planning this TNT, then we should have a very good backup of our surgeon. We immediately we can get help from them to get out of this disease. So it's very important that this is new technique which is coming in a big way, and we have to select the patient optimal patients, and we have to offer them this advanced technology and modality of the treatment. And thank you very much for all for your patience. Yes, ma'am.
Do you opt for MRI every 3 months?
It's not MRI every 3. It's local because the growth occur locally and 20-25%. That's why DRE and local examination is very important. For metastasis, it's not an MRI every 3 months for metastasis because but they show in your study that the 22.5% patients who have the recurrence, who have the disease, that was the local, not the metastatic. So that's why it's very important to follow up this patient and to do a active surveillance for the local part. And also, if you suspect anything in this patient, then you can do a auxiliary sonography, CT scan, and if patient has symptoms.
So how common is this kind of response in rectal carcinoma? How common is this response in?
So I have shown that 70% patients have response of CTRT.
CTRT. It's a good thing.
So when will you decide that the patient is not responding to CTRT? Suppose you have given first 2 cycle or 1 or 2 cycle, and after that patient is still having there are the new meds or the growth is not decreasing. So when will you say we will shift it to the chemotherapy or to surgery?
So now I have to invite our radiation oncologist.
Really? About the radiation oncologist.
How you will do?
We cannot plan 2 or 3 cycles. We give complete. And we give complete dose of radiation. That is 45 gray to 50 gray.
Even if the size is not decreasing or the new meds are appearing, they will continue with.
So
In most of the cases, they give a response to radiotherapy. In most of the cases, it is very uncommon that patient does not respond to radiotherapy.
And locally, even in locally, you have to evaluate after 2 months of the radiotherapy, not immediately.
Another question for clinical features. Do the rectal bleeding is painless or it is painless?
Yes, ma'am. Actually, it depends upon the stage of the patients and tumor size. If it is early size, it could be it is usually painless and bleeding. And when it involves the surrounding structures, then it becomes a painful.
Dr. Jasuja, good morning, and this is really a phenomenal presentation. All the good work that you are doing at your sector with the help of your senior colleagues, Dr. Sharma, I can see Dr. Suresh Singh, and the multimodality treatment that goes on over there. But at this point in time, with oncology practices, as you have highlighted, precision oncology, that's the buzzword. And here, we also come into picture. So, from the Department of Pathology, I want to make a request at this platform that please, and be very supportive to it, because we are all set to start molecular oncology. So taking the small steps, we have a small molecular lab here where we are really wanting to get started, not asking for anything. I think the administration, the government has already made appropriate kind of, approvals and things, but it's basically from our own
college and administration that we really need to sit together and get started. That's my request,
Sure.
Dr. Suresh Singh, Dr. Sharma, and Dr. Jasuja. Thank you very much.
Well taken. Thank you very much. Thank you, ma'am. Thank you very much.
Congratulations to the Department of Medical Oncology for presenting the excellent case, which truly highlights our ultimate goal of providing good quality of life to our patients. That goes beyond treating the disease and to embrace patient-centric care. But this comes with underlying responsibility. Thank you.
So, a very good case presentation. I would say that it was indeed a multidisciplinary approach, but the basic अब हम पूछें कि why it is put in CPC is the what outcome has been brought up by this CPC is in the treatment outcome. We have tried upon without surgery the treatment which is medical as well as with the combination of radiotherapy, and the results were really good, and the patient has been followed for now 9 months, and they are going to put it on strict surveillance because the key of success lies that the patient should be okay. So every 3 months they have to have an active surveillance so that the patient is ensured to get the quality of care he deserves to. Now the second important thing is that please try to capture the attendance more. Everybody of us has the moral responsibility of encouraging the residents because the first hour is of teaching. So you have to suspend your PG teaching and ensure that all the residents should come here in the CPC. And often the blame is being put on the principal and the additional principal to put some efforts. But I think the effort should be done on the inner core of each faculty. So I request each one of you to please encourage your colleagues and the residents and all the other persons to come and attend this CPC. Second important point is, this is the month of organ donation. So I, being the information, education and communication convener of SOTO, I'll just request all of you to have a picture with the IEC material, and we are also showcasing the digital pledge which you can scan with your QR code, and please take the organ donation pledge. See, if we take organ donation pledge and put it in your status, that will encourage all the other common person, and the message has to be spread across because many people in the waiting list are dying because they don't get organs. So let us all have this campaign and make the sea change in each one of us as well as in the surrounding environment. So I'll request all of you to please have a picture with all of us so that we are going to put it in various places. People may get encouraged. Thank you all. We have upcoming UG exams followed by PG exams. Please do not forget to fill the annual disclosure in correct way. If you have any difficulty, please ask any one of us from the academic section. Thank you all for patient listening. We will have a cup of tea and samosa, but before that we are going to click and we are going to put a thumbs up that we are going to support organ donation, and today itself we are going to take pledge. I have taken mine. Thank you.